you. After lunch is the toughest session to be in and to host, but I hope we'll have some cool conversations, conversations that matter, conversations that we hope will bring changes. I want to start by thanking the team at ETI, that's Shireen, and everybody else, including Avantika, Hardik, Khushi, who's come here and traveled to attend this session. Thank you so much. It's not going to happen without you. So also now I'm just going to invite the panelists, and instead of me reading the bios, it will be very nice to just hear, what you would like to introduce to the audience as we continue to talk.
Sure.
Can we have the panelists, please? आज का सेशन हम थोड़ा मिक्स इंग्लिश और हिंदी करेंगे. I just think it makes it easier. There's a flow to it, but of course, as panelists feel comfortable, I just want to extend a warm thank you to all of you for taking time. Dr. Bhan has just flown in today for this session, and I would encourage everybody to find time with the panelists once we are done. Dr. Aqsa, we'll start with you, and I'll request a brief introduction on her. देखिए नीचे से.
Hello, good afternoon. No energy in the room. Good afternoon.
Good afternoon.
Thank you. I'm Dr. Aqsa Shaikh, and my pronouns are she or her. I'm a medical doctor and a teacher. I teach medicine at Jamia Hamdard University in Delhi. Also a proud transgender woman and a vocal activist and advocate for the rights of trans persons. And here to have, as Sukriti mentioned, some cool conversation. I can also understand Marathi, as the air hostesses say. Or, sorry, air hostess is a very gendered term. Flight staff says. So, yeah, we can also add some Marathi to the conversation.
Absolutely.
By the way, it's flight attendant now. So that kind of covers everything. Hi, I'm Neeraj Jain. I work for PATH. PATH is a global not-for-profit working in the space of health. And of course, we do some work also in the mental health space.
Thank you.
Hi everyone, my name is Anant, Anant Bhan. I'm based out of Bhopal. I am a researcher in global health, health policy, ethics and mental health. I'm also a adjunct professor at Yenepoya in Bangalore. Nice to be here.
Good afternoon, everyone. I'm Shubhrata Prakash. I'm an officer with the Indian Revenue Service, and at present I'm posted as director at Niti Aayog, although I'm here in my personal capacity. As a mental health advocate, I am also the author of the book, The D Word, A Survivor's Guide to Depression, which is about depression. And I do a lot of advocacy for mental health in the workplace and otherwise as well. And I'm really happy to be here today, and I'm really looking forward to this session. And if I may just add that I also have ADHD, so maybe I will be talking a little about neurodivergence as well today. Thank you.
Thank you so much. Like I said, the conversation, this is going to be a conversation. There's no formality. There will be no presentations. There will be no PPTs. There's going to be experiences we share. What we need to change in workplaces, do we need to change this in workplaces, what's the problem and how are we addressing it? We have leaders here who think about policy, who think about their employees' safety, security, and on that I'm going to start with you, Dr. Aqsa. बहुत favorite terms हैं आज, or diversity and inclusion. Throughout this conference I've heard that happen. But do you really think, when we talk about mental health, diversity and inclusion के lens से अगर उसे देखें, how do we actually integrate the two effectively, in your experience?
Very complex question. I'll try to answer it in a simple manner. I think, when we are looking at diversity and inclusion, we are often looking at people who do not fit the box. We are looking at exotic specimens of human beings. We are looking at people who need our sympathy. But we need to understand that each one of us has diversity. And understanding that is important. Also, at the same time, understanding our privileges is important. People who come from marginalized backgrounds also have privileges And sometimes it's important to understand that. And here comes the concept of intersectionality. So when I say that, I am a trans person, I introduce often myself that I'm not only a trans person. I'm, for also example, a Muslim. And I don't have to introduce that because my name speaks about that, before that, even if I may not be a practicing Muslim for that matter, or I may not be believing in Islam, but just because my name comes, that aspect comes. I come from a linguistic minority, from Konkani, for example. I am a migrant in the city. I'm also a woman as perceived legally. So there are so many layers, and all of these ultimately impact your mental health in a positive or negative manner. And therefore, it's important that when we speak about these DEI conversations, we look at the intersectionality lens and look at how each of these contributes to. Because certain things, are very fancy. Like, for example, hiring a disabled person is very cool. But when it comes to when we ask people, what about hiring a Dalit person? Then it's like we don't talk about caste over here. We don't talk about religion in our organization. Everyone is same. So somewhere it's important to have those difficult conversations, to look at those prejudices which we all have, and to be accountable for that.
Are we having difficult conversations?
Especially in panels like this, yes.
Yes.
But I'm not sure how much difficult conversations we are having back, in our offices or even in other workplaces, like homes, for example. As Anant was mentioning, in our informal conversation, that homes are also workplaces now, and not just for our house helps, but also for us. And we have to look at, those conversations also in our houses, for example, and not just workplaces or formal settings like a CSR conference.
Thank you. Neeraj, PATH is a global organization, and many of us look up to you as a leader, and we do. And so I just want to ask you, considering it's a global organization, it's been leading in the development sector, how do you approach mental health for your employees? And any examples you would like to share, because some of us are here leading organizations or part of organizations. So what does PATH do to address mental health?
Thanks, Sukriti. No, I'm not a leader by any definition, but I think this is something that's actually very close to us. We work in the space also, so I guess we're closer to it. But in general, I think a few things that we've done which have been quite helpful, and I think they've worked well. We still have a long way to go, but I think really looking at providing access to information, that's one major piece. Being able to give access to care for the employees, and I think we have a pretty strong employee psychosocial support sort of a mechanism that has been developed at PATH. We also, to be very, very specific, of course, the DEI conversation, and I agree with Aqsa that the conversation is more than the action at this point, but thankfully the conversations have started. So somewhere the action will follow. So, but within that, especially during COVID, a lot of this got accelerated, and we saw a lot of challenges that started emerging. PATH as an organization allows people to work from home. We are allowed to take leave. We have 3 paid access to counselors. No questions asked. People do go on sabbatical, even paid sabbatical at times. So that's also common. But yeah, and we were discussing this just before. It's not necessarily written in the policy because you can't probably generalize some of this. But it is happening. A hybrid work environment is very useful for a lot of people. They can choose when to come and when to take off. I think we've also, a lot of people who want to take vacation, we have a system of donation of vacation leaves. So if you've got a support group within the organization, people are donating their own leaves when somebody needs help. Finally, what we saw, which really sort of was very good, was even our donors. I'll give you an example of Godrej. Godrej supports some of our work on the ground. And they actually opened access for counseling, mental health counseling, to all our staff. and anybody from our system could actually access that and use some of those services. So those are some of the things that we're doing. I think still a long way to go.
That's a lot of things, and I hope they grow and reach all your employees. Thank you so much. From global to local, I'm going to ask Anant to comment that, if you look at rural India, healthcare by itself is a major issue. Do you think people have access to mental health services? What's the status there, and how can we build those inroads? Because the truth is that a lot of Indians stay in those spheres.
Sure, thanks, Sukriti. So, if you look at data pre-pandemic from WHO, it indicated that almost 1 in 8 individuals has some kind of a mental health condition. So that means that, if maybe we have around 40 people here, around 5 individuals would be potentially persons with lived experience of any kind, right? Now, some of that has gotten accentuated during the pandemic. There is data indicating, again, that in the first year post-pandemic, there was at least a 25% rise in anxiety, depressive disorders. Now, that's sort of the burden, but equally or perhaps more worryingly is the issue of treatment gap. And what we mean by treatment gap is that the kind of access which individuals with a particular health condition have to services which are affordable, accessible, quality. The treatment gap in mental health is close to 80 to 90%. So almost 9 out of 10 individuals who need mental health treatment do not have access to quality services, especially on time. So that's, of course, something which is even more higher in rural India. And the reasons for that are, of course, there is a reliance often on specialist treatment, which is to say mental health is often reduced to going to a psychiatrist or to a psychologist, and there is a shortage of these individuals. Medical officers are often reluctant to offer any kind of care. First of all, there is hardly any screening happening, for example, for even simple mental health conditions like anxiety and depression. There is, in fact, national programs now pushing hypertension, diabetes, screening happening at PHCs, even for cancer in some cases. But mental health somehow still is exoticized, and perhaps there is this stigma around talking about mental health, which is an issue. So in summary, the challenges are there across the country, but certainly much more in rural India. And the evidence already indicates that, hence, we of course need to do a lot more work from a public health perspective in responding to that, and not considering mental health as being separate, but mental health being integrated into primary care.
So just a follow-on question from there, what do CSR organizations contribute to? If they wanted to work in the hinterland, like they will ask you that, okay, tell us where we should invest. What are 1 or 2 ideas that come to mind?
Sure. So as I was saying, classically the reliance has been on specialist care, but there is again a lot of evidence which has been generated through large randomized control trials, that through mechanisms such as task sharing. Task sharing is effectively actually working with frontline health like ASHA workers, ANMs, nurses, CHOs, community health officers. You can actually deliver a large quantum of mental health care, because most people need care for simple mental health disorders, right? So anxiety, depression. Very few people need referral because they have schizophrenia, paranoid disorders, etc., the serious mental illnesses. A lot of mental health can actually be managed at the community. The problem is, one, we don't have good quality screening happening. Though there has been change, there is now, for example, the inclusion of a screening tool called PHQ2, which is a part of the ASHA CBAC checklist, the community-based assessment checklist, but of course that needs to be scaled up. ASHAs need to be supported to do it. We need models where at the primary health center, at the sub-center, at the health and wellness center, we are able to integrate mental health in a way that screening happens just in the same way screening is happening for other health conditions. We need to ensure that medical officers feel confident in prescribing antidepressants, and if they do, antidepressants are available at the pharmacy, right? We need to have mechanisms where counseling is something which is available. We need to ensure that stigma, which is a huge issue in mental health, and discrimination is addressed. That requires a lot of public engagement. That requires going out to communities and having open conversations about mental health. That, the thing about mere village mein 5 log hain aise jo pagal hain, the sort of negative connotation which is given to mental illness is talked about, because all of us could go through mental health issues at some point of time. I have certainly gone through them. Shubhrata has been open about her struggles. It's not something which is only happening to other people. It could happen to any of us. So I think if we do that, then we can support a whole lot of people, including, for example, pregnant women. Perinatal mental health, if we address that, that's another huge gap area. It doesn't just impact the woman, it also impacts her child. And that can have much longer ramifications from a public health perspective. So if we actually make mechanisms for making mental health available and accessible at the primary care level, which we could avert a lot of the burden that I spoke to. And then, of course, good quality referral services so that whoever cannot be managed at the primary care level is supported to go up right up to, say, a district psychiatrist under the mental health program. So things like that would help, and CSR could play a role there.
Okay, thank you so much. Shubrata ma'am, honored to have you, and congratulations, 6 years of your book today, and I hope we see a new one very, very soon. But just wanted to get to the point which you and I have been talking about it. Neurodivergence in the form of ADHD, autism is found in India, rarely talked about, we both know that. And what can we actually do to address these challenges? There are people in the audience who raised this yesterday that, we want to work on issues like autism, ADHD. Let's talk about it. Let's try to change it. Your thoughts?
Yeah. So as we've been discussing so far, and all the speakers have talked about this, that there's very little awareness about mental health in India as such, and there's a lot of reluctance on people who have mental health conditions to open up and, own it up or speak about it. And own it up, I'm just saying it in a very casual way. It's not something wrong or bad that, in the traditional sense of owning up. What I meant was also owning up in the sense that it's something that we need to do something about. That's the sense of using the word owning up here. So as a result, what happens is that, the silence and the stigma, they just keep sort of supplementing each other and providing, each provides a more conducive environment for the other to grow. So even for someone like me, I found out I had ADHD just, it was just by chance. Because when I was looking at ways to help myself when I had very severe depression, I was given a particular medication to help me with depression. And I suddenly found that I was undergoing a training program at that time, and I suddenly found that I was able to pay attention in class. And this was really strange because I had spent all my life sleeping through class. And because I was an achiever, a school topper, etc., so this was never highlighted. Nobody even noticed that I might have something like this. And when I looked up what is this medication that I'm taking, and then I found out that there's something called ADHD. And I'm talking about, this is as late as 2014 that I'm talking about. So then I looked up the symptoms, and I fit all the symptoms to a T. But when I took it to my psychiatrist who was treating me for depression and anxiety, he laughed and he said, no, don't even talk about this. You are an IRS officer. How did you clear the civil services? You wouldn't be there if you had ADHD. And ADHD is generally little boys, they don't even clear their 4th grade or 5th grade. So that was the attitude of a psychiatrist in let's say a tier 2 city in India in 2014. It's that late I'm talking about. But apart from the other issues that I had, apart from the debilitating depression that I had, I could not get out of bed. That is the time that I am talking about. So this was something that I somehow did not give up. It was something like, almost like being a dog with a bone, that I just had to get to this, that do I have this condition or not, because it's talked about a lot. But fortunately, since then, I started looking up, and I started, seeing a lot of conversations about women being diagnosed much later on in life, and getting diagnosed. A lot of women were getting diagnosed with ADHD. So I just kept at it, and fortunately in 2019, my psychiatrist in AIMS, he was very open-minded when I took it again to him, a different doctor this time. So he listened to me. And then I underwent a whole process of, cognitive analysis, and then I got that formal diagnosis. So this is me, this is one of the privileged people in this country. It took me so much. It took me patient advocacy for about 6-7 years to get a diagnosis. So that is the level of awareness. People don't know. In fact, even after a diagnosis of a psychiatrist in Delhi, not my primary doctor, but someone else said that, no, 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 don't open this can of boxes, because once the moment you speak about it, that you are an IRS officer and you have ADHD, so parents of children with ADHD will start coming and, bugging us. And it's not real. I've also heard that it's not real, and it's just something that's, it exists for the pharma industry to, push their products onto unsuspecting people. I don't know. I'm not an expert. I have not done research on this area, but I doubt that's all that there is, because if you know. If you've had it, you know you're different. I've always felt this little, the difference of, how you interpret things, etc. So coming back, sorry for this long digression, but I think this was important this is something that needed to be said, because otherwise we will not get to why we need to talk more and get more on this. So this is one of the reasons that the professionals themselves discount it. I was gaslighted to the extent that a doctor in Delhi in 2020, not my doctor, but before a session like this, a pre-session that we had, said that it doesn't exist. So,
And then he went to session?
it was an online session. I had promised someone else. This person was not the organizer, but
Okay.
it was really triggering. It was very, very triggering for
Of
me. I
course.
cannot tell you how bad I felt when I heard that. So look, I am not a specialist. I am not a doctor. I'm not a psychiatrist. I'm not a neuroscientist. Because ADHD is not a mental health condition. It's a neurodevelopmental condition. So it's something different. And I am not someone who can say with authority that it exists or it does not exist. But given the fact that something like this has been highlighted as a neurodevelopmental disorder, and these are the symptoms, I did see myself there. I did go advocate for myself. I got, assessed by someone, and I got a diagnosis. So, Sukriti, I really don't know where to even begin with this. And with autism, it's even worse, because a lot of people, and again, one needs to, I think, underline this, that whether it's mental health, whether it's depression or anxiety or just normal mental health, or it's disorders like ADHD, autism, they are all spectrums. Even mental health is a spectrum. So people who have autism and who are really in that severely impaired part of that spectrum, people call them mad. So there's just a long, long way to go. And this is probably where organizations need to step up. They really need to educate themselves. And I think mental health professionals need to step up. Nobody should have to go through what I went through just for a session, not even a professional I was seeing for myself.
Thank you. Thank you for sharing. So from the point that, ma'am raised about the different, the feeling the difference, or, being that different, Dr. Aqsa, let's talk about transgender inclusion in workspaces. And we know that there is discussion around it, but it's fairly recent. And there are a handful of institutions that have tried to bring this change. But the honest truth is, it's a very hard and very long road to walk on. I have personal examples of friends who could not even sit through 15 minutes of an interview because the environment was so toxic. So how do we address this, and how do we really bring inclusion at its true value?
Talking about trans rights and issues is a very sexy thing to do nowadays, whether it's media or whether it's conferences.
Definitely.
But unfortunately, we are not able to make changes on the ground. I'll tell you an incident which is just 24 hours old. Yesterday on Twitter, a doctor posted that all these transgenders on the traffic signal who ask for 10 rupees and beg and harass, they're such a big nuisance. And then there was a series of toxic comments which came, that they are actually men who dress up as women and beg 10 rupees. Someone calculated they get 200 clients every day, so 20 into 200 is equal to 2,000 per day. That's 60,000 per day, which is more than the salary of a postgraduate in India. Then someone said that they are one of the biggest nuisance and blackmailers and all. And I found out that this person is the one who actually treats trans people in the he's an andrologist, a urologist, and performs gender affirming surgery. And I was like, if this is the attitude of the doctors who are treating trans people, then you can imagine the attitude, in general, in the society. And they are always like, why are trans people not working? Why are they not getting educated? It is easy money to beg. And I always ask this question, भैया बहुत आसान है, कल से तुम भी छोड़ दो कॉर्पोरेट नौकरी, साड़ी पहनो, ट्रैफिक सिग्नल पे जाओ, नॉक करो, 10 रुपए मिलेंगे, 60,000 महीने के, why to do this 8 to 4 वाला job? So when someone is there, unless you are in their shoes, you cannot understand that what seems like a very easy thing to do, what are the compulsions and reasons behind that? This is traffic signal. Let's come now to an institution like a medical college. And I'll contrast between two. So when I was a medical student, and that was the time when I came out as a trans person, and now I am a medical teacher, and I have a trans student also in my medical college. And in these 15 years, I see a lot of contrast. Okay, that's
Sorry.
someone else. Yeah, so at that time, the attitude was, don't ask, don't tell. When I came out to my teachers and colleagues, they were like, okay, I hear you, I do not understand this, and I do not want to speak on this. So let's not talk about it. And that was the time when it was pathologized. It was considered a disorder. Coming to 2020, when it's no longer a disorder, when we have a law which says trans people should not be discriminated at workplaces, there is a punishment of 2 years if you discriminate a trans person at workplace. There are legal provisions and everything. As they say, the more the things change, the more they remain the same. This trans student I was talking about is not able to come out to other people in the institution. There's no transgender toilet. There's no provision in our academic forms for them to write that they are a non-binary person. And there is no discussion, in spite of me being in that institute as an out and proud trans person for 10 years. So somewhere, it's a good start. And as Neeraj also mentioned about employing 2 trans people in the organization, but it's important that we don't feel, okay, we have done enough for trans people, ho gaya ab, and it should not be a photo op. 19th November is Transgender Day of Remembrance on Saturday. And we'll see a lot of organizations pink washing, purple washing, and saying we have a trans employee. But what beyond that, is the conversation that needs to happen.
Maybe on that point, Neeraj, what's beyond that?
Well, firstly, I'm going to call comms and say, don't do that. Huh? now you scared me. I'm going to tell them, even if you were planning to do it, don't do it.
Absolutely. What is beyond this? Beyond the 1, 2...
So, I'll just go back to the whole idea of inclusion, and that sort of goes across multiple areas. And, I think Aqsa ji is actually, when you started talking about the way, you said, start with trans, go to religion, and as you started peeling that onion, trust me, you've opened my eyes, because I've learned a hell of a lot, and clearly there's a lot more there. We talk about disability. I mean, we're not still getting the 2 genders right. So, there is a lot to be done over there. But I'll just come back to the topic of, mental health. And I think one of the things that we've noticed is that there are 2 sides to it. There is the demand side to it, and there is stigma, of course, attached to that. And people are not accessing services. And then there's a supply side to it. We just don't have enough professionals out there. And I think as organizations, all of us have a certain responsibility to try and bridge that in some way or the other. And what we've tried to do is really to focus on looking at, and it can't be just online, and it can't be just offline. But if we have to reach this large population, one of the things that we've been working on, Sukriti, is to see if the initial sort of outreach could be through digital. And a lot of work has happened in that space. I mean, I'm reaching out, my kids I have 2 boys, 17 and 15. And I find myself sending, I don't know what they call them even, personal messages on Instagram. What do they have a name for it, right?
I have no idea.
Okay.
What is it?
Direct, DM.
Oh,
Yeah,
that I
DM.
knew. I didn't remember.
And I'm like, he's in the other room. Why am I sending him a DM on Instagram? It's not even WhatsApp anymore. So clearly they have access to that. They feel comfortable with that. They're very happy to respond to me on DM also. And when they need money, they also DM me. So, but they're very comfortable. So the people are very comfortable using digital technology, interacting with it, accessing it, possibly also talking about their challenges and what they're feeling, etc. on that. So that's the demand side of it. And then you have the supply side of it. Are there solutions out there which are doing that, which are providing that platform to be able to do that? And then also making sure that it doesn't just stop there. And after they've gone through some of that process, are they getting access to services which will require maybe some physical interaction? So that's the direction that we're trying to go.
Thank you so much. I know we have about 26 minutes, but as we have this conversation, I'll also encourage the audience you are welcome to critique. I will say it first. You are welcome to question. You are welcome to say what you feel like. It's a safe space. It's a safe discussion, and that's why we are here. We are here for you, and we'll take the questions towards the end. But turning to Sukriti ma'am, we are talking about vulnerabilities, and there are examples after examples of, taking into account what women face at work. So I do know that Sangath, for instance, has a menstrual leave in place. ETI has a menstrual leave in place. We are not going to say, please take a special day off, apply for menstrual leave. But can you just shine some light on the struggles, number one, women face? If there are any examples that you'd like to share, especially related to issues like postpartum, coming back to work. Ma'am.
Okay. So, Sukriti, to look at the first part of your question, the question about what women face. So, I don't think I'll dwell a lot there because that's something that, I think most women here in this room would know. And also, those who have supportive partners, they would also know that what your partners go through. So, either way, so let me just come back to the postpartum question, and especially I think that's significant because I guess I first started having depressions, showing signs of it postpartum. So apart from the fact that I was not screened for it, maybe there was no awareness at that time. But with the changing times and with there being more awareness about mental health, about depression, and of course about postpartum depression as well. So this is something that I have been advocating for, that probably women who are in the postpartum phase, if there was more support, if there were the hospital staff, the nurses, the doctors, if they were trained to screen at that stage itself. And maybe in the rural areas, I think Dr. Bhan is working on something like that, like if the healthcare workers even who go down to the level of the villages and panchayats and they talk to women there. So some screening, because a lot of women go through postpartum depression or even just feeling low. There's a difference between the two. So, and for a lot of us, our journey with depression starts there. So that's something I would really like to highlight. And there, what workplaces, like, of course, I work with the government and the structure is different. But even, the private organizations and other workplaces, what workplaces could do is keep this in mind, that this is an issue, First of all, that is this something which warrants a little bit of attention? So definitely this does. And postpartum women need support in many different ways, maybe a little bit of flexi working and stuff like that. And there was this controversy about an IAS officer with child she was holding in her arms when she was delivering a speech. I think this was last week or just a couple of days back. So when I was thinking about it, I remembered the days, even I have carried my newborn to office because there is work. And I'm talking about 2006 when we didn't have emails and, I had to conduct my hearings and there's limited time to work. And it's all right to say that, my baby was like 7, 8 months old. No, I'm not talking about a 4 weeks old baby. So those are the other extreme cases, which again also land in controversy. We were just discussing that. But sometimes we just don't have a choice. I've done that because where else? How else will you complete the work? And all the help that you hire, etc., is fine. But if you are working a 14-hour or 15-hour day, which I have done as a young assistant commissioner, sometimes there's little choice. So these are a few things. But of course, things have changed in the meantime. And with work from home being a possibility, which has been used by all organizations, whether the government or private organizations, I think it's really, really possible to give women who have just given birth more flexi work, flexi timing, so that they don't have to carry a 4 weeks old baby to office. That's something that we can look at, definitely.
Thank you so much. From the point of, what ma'am has just raised, Dr. Bhan, you have worked extensively with frontline workers who are all women. They were the ones at the front of the pandemic. They were the ones who faced a lot for us. So how do we really take care of mental health for those who have cared for us and protected us through something like COVID-19?
Sure, thanks, Sukriti. So, one of the things we need to reflect on is what is normal work life, inverted commas normal, mean for these individuals at the front line. So let's talk about ASHAs or ANMs as an example. They often work in fairly stressful situations where there is a shortage of resources. Human resources available at their disposal at the facilities that they might be working in. During COVID, there were many ASHAs who talked about the fact that they did not even have gloves or masks, and they were expected to go out to communities and do screening, for example, or deliver messages. So, of course, putting themselves at risk, their families at risk as well. On top of that, many of them don't get their salaries on time. Some of them are on incentive-based payments. There are many ASHAs who've not received their incentives for sometimes 5 months, 6 months. And anyways, it is a meager amount. It is sometimes less than minimum wage for the states that they are working in. On top of that, you have bullying and harassment, which is rampant in the health system. I think any of us who's trained in the health system knows that this is something which might be hidden to the outside world, but it is clearly a huge issue, and it especially falls more severely on those who might be lower in the hierarchy, because then everything gets piled on them. And then also these are women professionals who are balancing their work responsibilities with expectations from their communities, with expectations from the families they have been married into, and so sort of societal expectations. So add all of that in, plus COVID, and then of course you had many situations where perhaps there was just a lack of attention. There was a lot of expectations, but not adequate focus on the health and well-being of these individuals. And in our work during COVID as well, as Subrata was mentioning, we do a lot of work with ASHAs, especially in training them to deliver psychosocial care to communities. Again, evidence-based, simple interventions, where there is, which is something that they can do even at the level of a household. But some of them came back to us and said, it's great that you're working with us to deliver psychosocial care to communities, but what about us? Why does no one talk about the fact that we are also facing these kinds of symptoms? In fact, when I got trained by you, I realized that all the symptoms that you're listing on the slide as symptoms of depression are things that I have undergone. But no one ever talked to me about it. No one screened me ever for it. And so who will work for us? And that made us reflect as an organization. Because of course you can keep doing projects, but if you're not accountable to the groups that you work with, then there is obviously, and this is perhaps an open sort of question to all of us who work in this sector, that what do we owe the communities that we work with, and should we not also try to generate our areas of work from what they are telling us? So it made us actually write a proposal where now we're working through a positive psychology-based approach to try to focus on mental health and well-being needs of ASHAs and try to generate evidence of what is the right model to be able to do it in a way where we recognize also the broader structural determinants and the intersectionalities which Aqsa was talking about. Because it's never just enough to say, let's bring more antidepressants into the system, let's provide psychosocial care without addressing the broader social determinants as to what are the stressors at the workplace. We need to have those conversations. So that's one example of what we've done. We've also done some work with funding from the Wellcome Trust, where we've tried to focus on team resilience approaches, because again, the health space or healthcare delivery is a team-based approach. You know, you can never just function as a doctor. You need to work with the nursing staff, you need to work with paramedical staff, you need a whole slew of support services. So how can we actually engender more team-based approaches where people are supportive of each other and respectful of each other, and what is the evidence on that? So I think our role has been more on the evidence generation side, but also then working with the health system to try to implement some of that and scale it up. And hopefully some of that in the near future we'll have evidence of.
Thank you so much. Dr. Aqsa, policy हम बहुत बनाते हैं और laws भी बहुत बनाते हैं, but specific to transgender community, there are policies. Number one, the question is, do they work? Are they working, or what else do we need to do? Number one. Number two, we were talking in our pre-session how there is no recognition for the LGBT community. Your comments on that?
Before I answer that, just a quick thought on what Neeraj mentioned about digital mental health
Yes.
care services. And that's, one of the things which has been a topic of concern for us. One is, digitalizing everything is not the solution, right? And if it is done wrong, it can actually end up doing a lot more harm. And when it comes to mental health services, that's one area where digitalizing needs to be done with a lot of care. First of all, there is no anonymity as such in digital care, which is generally thought that digital hai to anonymous hai. We all know that if I know your date of birth, gender and PIN code, I can easily find out who you are, So there is this question of data privacy. And I say this because of my experience of working on the CoWIN app. And how that data was so unsafe, and no one was accountable. We didn't know who was the developer of the app for a very long time, whether it was a government-developed app or a private-developed website. And where is the data stored on Amazon Web Services or something? So that one has to be mindful, because a lot of push will happen for digital mental health care provisions in the near time. So we have to be cautious about that.
If I may just come in, I would like to hear what he has to say, because
Yes.
he told me I'll throw questions at him. So I'm throwing my data privacy.
A huge issue. You're absolutely right. I mean, I have no argument. I still don't know who made CoWIN. Huh? Do you? I don't think any of us do. So, huge issue with data privacy. There are rules which are being formed, but it's a balancing act, because the need is so large. We work in a lot of low resource settings in urban as well as rural areas. And there is no way, we just don't have the kind of professionals that we need to be able to do to reach out to some of these people. And the stigma and even the understanding is so low, and the acceptability. So, I'm with you, Aqsa ji. We just have to probably find a balance. And maybe we should talk more and find that balance and, advocate for that.
Definite. To the question.
And one way of finding out that balance is to include people who are going to be your beneficiaries as the decision makers and stakeholders. Coming to do policies work, I was in one of these sessions where someone said, "Arey Aqsa, तुम क्या transgender policy की बात करती हो? तुमको पता है dowry India में कब ban हुआ? तुमको पता है child marriage कब ban हुआ? But you know what happens in the real world? Everyone takes dowry, IS है तो 40 lakh, those kind of things. So it's like, what are you talking about policies? And Transact is just 3 years old, so that's there. But what is important, and I keep saying is, it's important to create those policies and laws. It's important to put them on papers. They may not be fully effective in terms of the implementation, but that's a start. And I say this very proudly, that India is one of those few countries which has a legislation for transgender persons. If you look at the United States of America, in the last year, they passed nearly 300 legislations against trans persons in various states, especially on bathrooms in schools. So that way, in the Indian culture and our Sanskriti, the trans persons are very much recognized. But the problem comes the moment we talk about the LGB, क्योंकि वो हमारी संस्कृति का हिस्सा नहीं है. The problem comes when we talk about equality of marriage. The problem comes when we speak about, partnerships of various kinds between people. Because we don't want, and there is clear government stand that we don't recognize and we don't want to recognize marriage equality. And that has repercussions at workplaces when it comes to insurance for the families and spouses, when it comes to who gets the provident fund amount, when it comes to the leaves, for example, parenting leave. Why say maternity and paternity, very gendered. Parenting leave. I won't get parenting leave for my partner's child, for example. So those are the kind of concerns that we need. And while for trans persons policies are in place, we know that they're not being implemented on ground. It's important to work on that. I know of a lot of organizations who genuinely want to do that, but there is this worry that we'll not be able to do justice to a trans employee if we hire them. And I always say them, when you decide, when many of you may be married, when you decided to get married, were you adequately prepared to get married? No one is ever adequately
Never.
prepared to get married, right? When you decided to become a parent and take the responsibility of another human being, were you adequately prepared for that? Never. So similarly, when it comes to taking the responsibility of a trans employee, you will never be adequately prepared, but you have to take that, push, and slowly things will happen. So that's the important message. Ki karke dekho, hoga.
Thank you for that message. Coming to policy, Dr. Bhan, in the pre-discussion session, we were talking about what should a health policy look like, or a mental health policy. What does it look like? And I think all of us will have a takeaway from that. So some comments.
Sure. So as Aqsa was saying, there are certain things where there are sort of legal requirements, right? So you have the Transgender Act, which came a few years ago. In fact, there is a requirement for all institutions to have a equal opportunity policy, especially for transgender employees. I don't know how many of you have it. When we started working with marginalized communities, that was one of the first things we realized when we read the Act. Most of us haven't read the Act. And so we formulated one. But this is something maybe as a key takeaway for all of you who work in organizations to reflect on it, because this is a legal requirement. That having been said, as we were discussing earlier in our small group as well, there is a legal requirement to have creches at workplaces. How many of our workplaces have creches as well, right? But coming back to the issue around policy, I think, one of the things is the struggle sometimes with mental health at the workplace is that because of the stigma, and I'm talking about someone who works with a mental health organization, even in our workplace, many employees might not feel very comfortable, for example, saying that I'm just drained, I've had a long work week the previous week, I just want to take Monday off as a mental health break, Actually, I want to ask, has any of you ever applied for a mental health leave or leave on mental health grounds? Great. So has any of you mentioned a leave on mental health grounds for grades? Good to see at least some hands coming up. I'm sure all of you have sanctioned leave for physical health conditions, right? And most of us have sought leave for physical health conditions. How can we transition to workplaces which allow for people to not feel uncomfortable, saying that I just cannot get out of bed today, or I had a bad fight with a partner, a friend, and I just don't feel like coming to work today, I cannot focus, and not feel judged about it, right? So that's the kind of a rampart that we need, but we need a structure, and that structure can be the policy, because what you don't want is every supervisor to struggle as to what is allowable and what is not allowable. If you have a broad policy which gives you at least some clarity around what are the kind of grounds on which you can, whether that be a day off, whether that is work from home, whether that is a flexible work day, whether that is offering counseling services which are supported by the institution. So you say, you can go access services from outside, no questions asked, we will reimburse up to whatever 5,000 rupees or 10,000 per month. Things like that need to be there in the policy so that it is not left to the discretion of an individual line supervisor. There is some clarity that this is something which is acceptable and encouraged, and here is how you do it. And so no one can question it at a higher level, at HR, at admin, at finance. So in the absence of that being the case, it will be left to the discretion of a good boss, in inverted commas, who might be supportive. And they might also struggle because they might say कि अगर आपको छुट्टी दे दी तो वो पूछेंगे, वो बोलेंगे उनको क्यों छुट्टी दी, वो तो ठीक लग रहे थे, वो तो मेंटल हेल्थ का बहाना बना रहे हैं, मैंने उनको देखा कि वो तो मॉल में घूम रहे थे या पिक्चर देख रहे थे, maybe that is their way of taking time off work, right? How do you judge? So that's why we need some structure. So I think, you know, we've been working on setting up our own mental health policy, but also trying to make it in the same way not become judgmental, you know. So you need to have mechanisms which encourage people to feel free and that has been a learning process. Now, you know, 2 years, maybe 1.5, 2 years of having a menstrual leave policy, for example, it's very common for our colleagues who are menstruating to be able to write to their line supervisors saying that, you know, I want to take a day or two off because, you know, I have discomfort or I want to work from home, and it's normalized slowly. So we need to normalize conversations around mental health so that people feel comfortable seeking the kind of support that they need from the institution. Not always leaves, but also other kinds of support, which are, you know, I think in a good workplace should be there. So it comes back to the issue of what can we do collectively to make those kind of conversations happen. And for those of you who are supervisors, start with yourself. Take time off if required as well. I'm sure all of you are also sometimes in stressful situations. That sort of percolates down when you see people who are up in the hierarchy also saying that, you know, it's fine to do this, then maybe that will help others also know that it's okay to talk about mental health.
Thank you so much. To feeling safe, and I know we have a few minutes, so I'll just ask Sukriti ma'am the last question, and then we can take some comments from the audience. You are a very active mental health advocate. A lot of us follow you, and you know, we all of us have moments where we are uncomfortable. Sometimes we don't know, and I'm going to actually ask this personally as well. What is the takeaway message if somebody is struggling, say, in a workplace or in their personal lives? Like, how do we address it? And what do we take away from this conversation today?
Okay. So I'll answer your question in 2-3 parts. So the first part is that what can the individual do? The person who's having the discomfort or the person who's actually struggling with mental health. So there I would say that I always encourage people to say that, you know, just let the stigma stop with you. Like I just did that. I also told myself the stigma stops with me. You have to learn to not internalize the stigma that society is throwing at you, because this is what happened. I struggled with that stigma for such a long time. It hampers recovery, it hampers acceptance of the mental health condition, it prevents people from going out and taking help. Now, of course, this is, people would say that, you know, society, it's everyone's collective responsibility. Yes, of course it is, that goes without saying. And especially because mental health conditions are psychosocial, and, you know, but the thing is that you as an individual also, you know, you have to, it's you, because ultimately it's your life and nobody else cares except you and your loved ones, what happens to you. So that is why at some level the individual should also, you know, just forget the stigma, forget what happens, forget what people say. Now, this may have consequences for your job, this may have consequences for your promotion, etc., for your children's marriage and God knows what. All those issues are there. I'm not denying that. Maybe I'm someone who was privileged enough to have a safe space and I could speak out. But that's something that as an individual, again, I cannot say much about. It's up to you. But on the other hand, for society in general, we also need to be supportive, and we all need to, you know, just accept that it's okay to not be okay. And for workplaces and for, again, society in general, I mean, of course, the extended family, etc., everyone has to come around, and someone who has a mental health condition can get better when they get this kind of support from everyone. And just to build upon what Dr. Bhan already said, that as far as my experience goes, because I keep talking about my personal experience all the time, so again, today, again, I'm speaking from experience, that it has basically been the boss's discretion, you know, depending on how good or bad the person is. I've heard stories about myself, like I've been the fodder for the gossip mills of the lunch clubs in office, that kuch nahi hai isko, theek hai, bilkul bahana karti hai, kaam nahi karna chahti hai. So from that to things like, after my book was published, 2 years after my book was published, a very senior officer told me, no, don't tell anyone that you may have a fractured mind, because, you know, who knows, someone will say that why don't you just leave and go and don't come back to office, because nobody would want someone with a fractured mind to work in office. I've heard this from a very senior officer. So I've had those experiences, but on the other hand, I've had wonderful support, very supportive bosses who've given me, especially with this flexi time, etc. You know, like, okay, come to office physically when you feel up to it, but you go on with your work, and all of that has been there. So it's been a mixed bag for me, and therefore, again, coming back to Dr. Bhan said that somehow we need to get this message across that, you know, whoever is making an accommodation for someone, let's say if it is gender, as Dr. Shaikh mentioned, or whether it's trans or cis, but you know, gender is an issue, we've all been talking about it, or whether it is neurodivergence, like I talked about, or mental health. Most of the interventions or the positive interventions are basically from a place of charity, you know, that I am a nice person, and this person is suffering or this person has an issue, so I help them, I address it, I do whatever is in my power. Now, that is something which should not be. Because people who are asking for more accommodation or, you know, just a bit of consideration for themselves, they are equally capable people. And it is their right. This has to be a rights-based approach. There has to be a rights-based approach to this. That these people who are asking, whether it's me, whether it's Dr. Shaikh, whether it's anyone, any of us here who have not spoken about it, we've spoken about our issues. So it should be that everyone deserves to have the rights that are available to everyone, equal opportunities, equal rights, and it just should not be based on charity. It should be, you know, like she said, that people will say, हाँ, काफी दिन अब trans का हो गया, अब चलो इतना तुम्हें दे दिया बहुत है. Or, you know, things like, you know, इनको mental health का problem है, ठीक है, इनको इतना time दे दिया काफी है. या अरे यार, उनके बच्चे को भी अब, a lot of people have kids with ADHD. उनके बच्चे को ADHD है, ठीक है, उनको time दे दिया. Or, you know, things like that. This is how it goes on. That shouldn't be. That just shouldn't be. There should be a rights-based approach, equal opportunities, and not from a place of charity, rather from a place of empowerment, and that you create an enabling and you know, suitable environment for everyone to perform, because most people are there to perform. I cannot say about people who have nefarious designs. That's beyond my remit here, but this is how I see it.
Thank you. Thank you.